Okay. Dear colleagues, good afternoon. It is my great pleasure and honor to be here, and I would like to thank Professor Papachoris and Dr. Melas for inviting me. Let me say first of all that I am a nephrologist. I'm not a urologist. I understand that the majority of the audience is urologists, but I'm a nephrologist. And what I'm going to present today is the optimal metabolic control for kidney stones, which is a metabolic control, of course, but which also has to be risk stratified, mechanism-driven, and aligned with all the contemporary urolithiasis management guidelines. And when I'm talking about contemporary guidelines, I'm talking about the standard of care, nephrology and urology approach, which is aligned with the European Association of Urology and the American Urology Association guidance. So I'm not talking about a generic checkup. I'm talking about a quantitative risk model, which is phenotype-driven and which is based on urinary supersaturation. The objective of this model, of this clinical phenotyping, is to reduce urinary supersaturation and modify all the promoters and inhibitors. Of course, increase the inhibitors and reduce the promoters. And this is just an idea of no metabolic workup to the left, and minimal metabolic workup, which is just serum and one urinalysis, standard metabolic workup, which is minimal plus a 24-hour urine collection, and what I'm going to present and elaborate on, which is the optimal metabolic workup, which includes 2 24-hour urine collections, plus the supersaturation calculation, plus the clinical phenotyping. And what is the first step in this optimal metabolic control? In practice, we are talking about clinical phenotyping. That's the target, that's all the story. And the first step in this clinical phenotyping is risk stratification. We need to identify the patients who are at the highest risk. And I have separated this paragraph in 2 parts. The first part is comorbidities. So I'm talking about patients who already have chronic kidney disease, or patients who already have a solitary kidney, or have some disorders, anatomical disorders, or patients who have diabetes or some GI disease. These patients are at high risk because they have the comorbidities. And the lower part of the paragraph is things that have to do with the stones. It is stones that start early, at an early age. It's stones that are recurrent. It is stones that are complicated. It could be bilateral stones, it could be infection stones, and it could be a positive family history of stones. All these patients are at high risk, and they should be we should do them a full metabolic profile. So in these patients, well, practically in all patients, we should be looking at detailed information about their history. We should exclude things like sarcoidosis. We should exclude the medications such as large quantities of vitamin C or vitamin D. We should exclude polycystic kidney disease because these patients make stones. And we should be certain that our patient does not have cystinuria or primary hyperoxaluria. And when we're talking about risk stratification, we should also be able to address the dietary risk factors of the patient. We should be able to address the imbalance between inhibitors and promoters, and we should be looking also at urine composition disorders. There's no need to elaborate on dietary factors that increase the risk for kidney stones. You all know that high consumption of alcohol, of salt, of protein, of sugar, of oxalates, and also the use of calcium supplements and vitamin C supplements can increase kidney stones, the risk of our patients for kidney stones. And we have presented in previous congresses, like in ESD previously, we have presented this imbalance between promoters and inhibitors. We would like to increase inhibitors, we would like to decrease promoters. And there is a large variety. Previous speakers today have already mentioned some promoters and some inhibitors, but there is a large number of such inhibitors and promoters. And what about disorders in urine composition? We know that hypercalciuria, hyperoxaluria, hypocitraturia, hypomagnesiuria, and hyperuricosuria, also urine pH and low urine volume, they can contribute to the creation of kidney stones. So what after risk stratification, which is the second step? We should go to the control. This is blood works, basic metabolic panel, calcium, albumin, phosphate, magnesium, uric acid, creatinine. As a nephrologist, I would never leave out creatinine because eGFR calculation is very important, and PTH and vitamin D levels, and urinalysis and urine culture. The 24-hour urine collection should include not only the classic parameters, of course volume, of course calcium, of course oxalate, citrate, uric acid, sodium, pH, magnesium, but also creatinine. Since you are asking your patient to collect his urine for 24 hours, once or twice, you should be calculating creatinine in those urine. And you should be also looking for albumin, since albumin is a very nice index for kidney disease, for kidney damage. And what about stone analysis? If available, or wherever available, stone analysis could be the cornerstone of treatment. We should be able to examine the stone as appropriately, which means infrared spectroscopy or X-ray diffraction, and we should be able to identify its components, not just the chemical values. I don't accept a report that is coming back to me saying the stone contains calcium and oxalate. That's not enough. That's not what I expect from a stone analysis report. So this is the second step as a whole, if you would like to make a photo. But what is the third step? The third step is the attribution of the clinical phenotype. So there are 5 key phenotypes. It's hypercalciuria, hyperoxaluria, hypocitraturia, low urine volume, and low urine pH. These are the key metabolic phenotypes. I'm not saying they are the only ones, but they are the key metabolic phenotypes. And if we go step by step to all these key metabolic phenotypes, I'm not supposed to discuss treatment today. I'm only discussing the metabolic workup. So I have to stress the threshold for calcium. When you're looking at urinary calcium, the best way to do it is to apply 4 milligrams per kilogram of body weight per day. Not just 200, 250, 300. And just remember that all the laboratories have different normal values. They might be just not helping you with the normal values they're giving. Well, when we're talking about hypercalciuria, it's always important to distinguish between secondary hypercalciuria and other causes or idiopathic hypercalciuria and secondary causes such as medication or supplements that may be causing hypercalciuria. What about hyperoxaluria? Here again, there is a big confusion about the normal threshold. There are labs that give 30, other labs that give 40. In general, values above 40 need to alert you. This is something that needs to be investigated. And in any case, you need to be certain that there is not any type of primary hyperoxaluria hidden somewhere here. And please remember vitamin C. Large quantities of vitamin C can increase, they do metabolize in oxalate, and they can increase kidney stones. Hypocitraturia. Normal values of citrate in urine is supposed to be 200 to 1,200, which by itself, as you understand, is a very large range. So it's not really helpful. We need values above 500 in order to be able to say that we help the patient to make less kidney stones. There are issues that can be connected to hypocitraturia, and that is chronic kidney disease, some degree of chronic kidney disease, and also acidosis, because it causes metabolic acidosis, and also some types of diet. Large quantities of meat or ketogenic diets can cause hypocitraturia. Low urine volume. I think it is self-evident. Increasing the volume of urine can be considered as the most effective or most influential population intervention. The question is, how much should we increase the urine volume? And of course, the patient is not asking about his urine. The patient is always asking, how much water should I drink? So the reply is that I would like your urine to be above 3 liters a day. This would be a very effective, or at least more effective, intervention. And what about low urine pH? And I bring you back to the talk earlier by Alberto Trinchieri, who has taught us that uric acid levels is not so important for uric acid stones as it is pH. So it is pH, low pH, that drives uric acid stones and causes uric acid stones. It's much more important. This is the next step of the optimal metabolic control, and it is the calculation of supersaturation. There are many tools, there are many ways to do it. And all the stone clinics, they do have some way to calculate supersaturation. We are interested in calculating all supersaturations, not just calcium oxalate. It should be calcium phosphate, it should be uric acid supersaturation. And it's not important which tool you are using. In my opinion, you should be using the tool that you know best, or the tool that is available. Try not to neglect this step, because this is a very important step. Robertson, who has invented lithoscreen, has presented in this publication this comparison, a comparison of the available tools for calculating supersaturation. And it is not important. He says that they're all good, as long as you know how to use them. The final step is the follow-up. We are supposed to intervene based on the values and the supersaturation. We're supposed to re-examine in 3 to 6 months and adjust our therapy dynamically based on the supersaturation changes. Does this do any good to our patients? This is a very recent study by a French group by Dodon, and they looked at this, what they called tailored kidney stone prevention, which they found that it improves the metabolic risk factors and it can reduce the rate of stones. So yes, there is evidence there that the metabolic control can help our patients. And the randomized control study is underway. This is a US study that is currently, they're currently recruiting patients, and it is randomized, and they're looking at the different results, comparing empiric therapy and targeted therapy. And this is done by the well-known to us group by C and David Goldfarb. So I'm closing my presentation, Mr. President, saying that optimal metabolic control is important because we are looking at identifying the clinical phenotype. Because urolithiasis is not a single entity, because it is a cluster of metabolic phenotypes which interact through urinary supersaturation. And the most effective strategy is to identify this phenotype, to target the intervention, and repeat the metabolic reassessment. But the thing that we need not to forget is that urolithiasis is not just a surgical disease. It is a chronic metabolic disorder. And without metabolic workup, it has been already said before, we are looking at more than or up to 50% recurrence rate. With metabolic workup, we're looking at a reduction in the recurrence rate about 50 to 70%. And moreover, and I'm closing with this because I think this is the most important thing that we need to know as physicians, there is lots and lots of evidence there that kidney stones and urolithiasis is related to systemic diseases. Patients with kidney stones, they have osteoporosis. Patients with kidney stones, they have disorders in their microbiome, intestinal problems. And patients with kidney stones has been proven lately that they have higher rates of myocardial infarctions, higher rates of cardiovascular disease, higher rates of chronic kidney disease, and unfortunately, higher risk, much, much higher risk for dialysis. Thank you very much.